Good evening. My name is Faris Hussain, and I'm one of the Medics Academy and FDocs team members. Tonight, I am introducing our speciality webinar speaker, Professor Phil Smith. Professor Smith is a consultant neurologist based in Cardiff. He has previously been the president of the Association of British Neurologists and the Associate Medical Director for Quality for the Membership of Royal College of Physicians exam. He is also currently the Sub-Dean for Assessments at Cardiff University School of Medicine. Having been taught by him whilst at medical school myself, I am very excited to hear his talk on neurology, asking the right questions. If you have any questions of your own during the webinar tonight, please post them in the dedicated Slack channel. The channel for tonight is #neurology and can be found on the FDocs Slack. I hope you very much enjoy the talk. Over to Professor Smith.
Hello, I'm Phil Smith. I'm a neurologist in Cardiff, and I've got a long-standing interest in question writing and the way that we learn through writing good questions. And this is at both undergraduate and postgraduate level. So I was going to combine the two things, neurology and question writing, and emphasize some of the things that turn up in neurological questions. So the overview of the talk, I'm going to talk through single best answer questions in general, and then the type of theme that crops up in questions that are related to neurology, essentially what is common and important, and then run through various other neurological conditions relevant to question writing, and to focus also on the ways that we might get questions right, even if we don't know the answers. And so in writing questions, we need to be aware that there are ways of getting the answer, not necessarily through knowing the facts. So neurology is a really great topic, and it's good not just because it is so clinical, that it still depends so much on the history and the examination, but also that the investigations are often low tech. It doesn't involve very expensive machinery, although, well, MRI scans and CT scans, of course, but these are becoming commonplace. But it relies more on history taking, on ECGs, on testing the urine and that sort of thing. But it's the examination and is often the first investigation of neurological workup. So a single best answer question is the way that most questions are asked both at undergraduate and postgraduate level. And the reason that we use single best answer questions is because these allow application of knowledge, not just factual recall. It's one thing just to ask for a fact, but we don't need facts these days because it's all available on our phone at the touch of a fingertip. What we need is how to apply facts in a specific situation. And single best answer questions give rise to situations and scenarios such as a GP might encounter or a surgeon might encounter. Every interaction we have with a patient is another scenario. It also allows to emphasize clinical uncertainty, which is what so much of medicine is about. There often aren't specifically correct answers to things, but everything about medicine is grey, and we must work with that uncertainty. And single best answer questions allow this, because the answers are not all absolutely incorrect or correct. There are often shades of that. And also, it allows us to test widely throughout the whole curriculum. So you can, at a single sitting, can test every bit of the curriculum, at least sample it. And it can be marked very quickly as well, because these things are computer marked. So a single best answer question then has 5 options typically, and one of them is the most correct. So it isn't a question of true or false. That would be a factual question. It is a question of which is the most correct, which is the best of the options. And this is the way that, that medical thinking works all of the time. it could be that leprosy and rabies are possibilities, but in this case, it was tonsillitis. It's that sort of thing. So we're going to work out which is the most correct. And you generally want an answer where it's 80% likely it's correct, whereas the distractors, the less good answers, are 50% or less likely to be correct. And that makes a really good question, and one where the candidate has to think it through. So this is an example of a single best answer question. It's quite a good one, really. So it's you've got a short scenario, usually 4 to 6 lines, something like that, that gives the key points without too much extra waffle. Of course, patients in real life do have things that are not relevant in their scenario, and it's up to the doctor to throw that out. But our job in writing a question is, if there is something that is not relevant to the correct answer, it's relevant to the distractors. So we need to inform each of the other distractors that there is some material in the scenario that could suggest that they are possibly correct, but there is only one truly correct answer. And in this scenario, you can see the answers. The answer is an ESR, but these are in alphabetical order. And you may not have realized when you were students that actually all of the options are in alphabetical order. So hence, there's no great point in saying, well, I've had 5 A's in a row already. The next one can't be an A. They wouldn't be that stupid. But actually, they're in alphabetical order. So it's randomized in that sense. So the next answer could equally be an A. So the themes that are included in single best answer questions are those that are common and important. So, and this is from the perspective of an F1 doctor and a general practitioner. That's how we guide the content of an exam. So common, of course, means that it crops up in a GP practice or in an F1 practice quite commonly. But important means life-threatening or life-changing. So an example of something that is common would be tonsillitis or meningitis, something like that. An example of something that is important might be meningitis or suicidality, or a baby showing type 2 dips, a fetus. So something where life is threatened. And so exams are full of things that are common and important. They didn't used to be. In the old days, it was things that were of interest to the department, and they would appear in exams. But nowadays, it's those that are common and important. And also, there are things that lend themselves well to having questions written about them. So an example might be the Glasgow Coma scale. Where when you ask people to write a question, people very often want to write one about that. And yet that isn't a particularly good question. It doesn't really get the students and the registrars thinking about it. It gets them just having to remember how to work out a general Glasgow Coma scale. And some things that appear in real life do not appear in exams. And so in neurology, it would be functional illness. It's very hard actually to write a question on functional illness and put it into a best of 5 context. It's a far more discursive topic that needs an essay, as is social problems and professionalism and that sort of thing. And a lot of psychiatry actually is difficult to put into a single best answer question. And the psychiatry questions that exist tend to look for facts and names of things and the exact bit of the section of the Mental Health Act and that sort of thing. It's quite hard to put a really good question into the greyness of a best of 5 format. So just to illustrate some of the things that will crop up in neurological exams in terms of a written exam, things that are common and important. So something that is common and important is dementia. And we sometimes look to one side and then the other. There's 3 of us, and 1 in 3 of us after the age of 85 will develop dementia. It's that common. Delirium is very common, and I'll come to that in a moment as well, very common in exams as well, as it should be. Epilepsy and blackouts, 1% of the population has epilepsy and more have blackouts, so this is very common. And head injury, of course, and so much you can do about head injury as well in the acute stage, so that makes it desperately important. Parkinson's disease and other movement disorders do crop up a lot in GP surgeries, and peripheral neuropathy, particularly relating to diabetes, is very common. And stroke, I put these in alphabetical order, but really stroke would be second in this order, I think, after dementia as the most important neurological disorders. But things that are common but less important, in other words, less life-threatening, less life-changing, and hence will appear less in exams, will be things like headache, and dizziness and tingling and tremor, and psychogenic things, functional things. These are very common in GP practice and would have to be included in exams. But things that are important because they're life-threatening and life-changing but less common are things like Guillain-Barré syndrome and meningitis and encephalitis. Motor neuron disease, not so treatable, but really, really important to diagnose it and make sure it's correctly diagnosed for the information we're going to give to patients. And multiple sclerosis will come up in exams quite often, increasingly treatable. As are brain tumours. We perhaps don't think of brain tumours as being so treatable, but increasingly genetic markers tell us that we can do specific things to help people with brain tumours. And deficiencies, including vitamin B12, particularly, will crop up in exams. But things that we will not see in exams, probably, although we do see in neurological practice, are rare things with rare, things that make neurology seem frightening and seem difficult. So corticobasal degeneration, for example, Creutzfeldt-Jakob disease, these are less treatable conditions. Of course, you can do things to help people, but you cannot cure those. Paraneoplastic, everybody thinks of those when they are faced with a neurological problem, but they're actually quite rare. I put rabies there, common around the world, very important around the world, but we're not going to see much of that in UK exams. Spinal muscular atrophy, new treatment out, incredibly expensive, but it's not yet amongst the treatable conditions in the UK. And Whipple's disease, I put that in because everybody says it might be Whipple's disease when they are faced with a neurological problem, and it never has been yet. So to run through a few of those then, the issue with dementia is that it is so common, and the commonest by far is Alzheimer's disease. The thing that we need to know about Alzheimer's disease is that it affects predominantly memory and verbal skills. It's less common that it affects the frontal lobe and executive function, less common affecting parietal lobe and vision in occipital lobe, but it is so common that it will be the right answer, even if a patient presenting, say, with a problem interpreting visual images, it's still quite likely that that's Alzheimer's disease because it's so common. The thing to know about dementia with Lewy bodies, this is the one that goes with Parkinson's disease, is that visual hallucinations are very common in that situation. So it is the reason why you might see a ghost, for example. So someone coming to the GP saying, I'm seeing ghosts, it's very likely to be dementia with Lewy bodies. It's said that Ebenezer Scrooge in A Christmas Carol might have had dementia with Lewy bodies. So these visual hallucinations don't speak. You might see a child or a rat in the living room, and you're seeing it in full consciousness. You know it's not real, so you're not frightened by it particularly. You think, oh, that's interesting. So that's an important factor with dementia with Lewy bodies. Someone with multiple infarct dementia, another common dementia, but almost always there is some history of stroke. And patients with this will typically present with, say, walking apraxia, so difficulty with gait, not so much weakness. And it's a situation that might not progress particularly. So once the vascular risk factors are recognized and attended to, then the dementia may not necessarily continue to progress. A very important condition for F1 doctors and beyond is delirium. So delirium is something that could happen to any of us, but it happens particularly if we are older, where there is less brain reserve. So we have a lower and lower delirium threshold as we get older. And things that can trigger delirium are many and various, but I suppose many people would think of urinary tract infection as being the thing that does it. In fact, that is probably not as common a cause of it. The most common, in my experience, is alcohol and alcohol withdrawal. So somebody coming in for surgery, for example, may not have declared their consumption of alcohol truthfully and may develop withdrawal symptoms presenting as delirium. But essentially, a doctor dealing with someone with acute confusional state or delirium will need to look for factors that are provoking it. And these are often metabolic or infection or nutritional, and thinking of things like hydration and constipation. And medication sometimes can push people into delirium as well. A very, very common important condition. And I mentioned there two things. That's ABC. We all know about ABC in terms of airway, breathing, circulation. But whenever we see anyone with loss of consciousness or loss of normal awareness and confusion, D, E, F, G, don't ever forget glucose. Think of low glucose in someone who is confused, as that to miss that is a terrible thing. So blackouts will crop up in neurological exam format all of the time, and not necessarily in the order in which they appear most commonly, because some 30% of us will have a faint at some stage in our life. It will be a simple faint, reflex vasovagal syncope, with all of the features, posture, prodrome, provocation. But the important thing about this condition is that it has such a good prognosis, and we can commonly recognize, we get it with the visual disturbance, the blacking of vision, that type of thing, that at the onset of it. Importantly, during a syncope, a normal healthy person having a syncope will sometimes shake, will sometimes jerk their limbs, and it can look like a seizure to somebody who is scared stiff watching their loved one having a faint. But if it is preceded by standing up or watching a gory movie or something like that, then it is a faint, even if it involves shaking and even if it involves an injury or tongue biting. Essentially, syncope is a healthy, exaggerated reflex. So it is the normal slowing of heart that goes with a reflex response to something. And it gets better as you get older. So this is a nice reassuring thing that you're less likely to faint as you get older. The problem is that when you do faint and you're a bit older, there may be a highly sinister cause, that is cardiac syncope. So the interesting thing about cardiac syncope is that the usually older person who gets it, usually with heart disease, they've got a scar on their heart, they will have an episode with no warning sometimes, just collapse at the dinner table or whilst they're mowing the lawn, and they will recover rapidly, which is paradoxical really, because they stand up after the faint and send away the ambulance which is being called on their behalf because they feel absolutely fine. And yet their mortality is 30% in the next year, whereas the person who has a vasovagal faint in assembly at school feels a bit woozy afterwards and accepts the glass of water and goes and has a nice lie down, and their excess mortality is 0. So it's cardiac syncope we need to be thinking of, and hence we're going to be doing an ECG for everyone with a blackout, looking, and particularly an undiagnosed blackout, looking for evidence of previous myocardial infarction. So epilepsy is very common, and we're going to see a lot of people with epilepsy in exams as well. And in practice, of course, we know that the issue with epilepsy is that it's all about the history. There is no test for epilepsy. You can do an EEG, but an interictal EEG can only ever give you a hint of what's going on. If you capture a seizure, then usually you will find there is abnormality on there, but there are seizures which start deep inside the brain, in between the hemispheres, for example, in a frontal seizure, that doesn't show on the EEG, even when you capture it capture a seizure on the recording. The issues we need to know about epilepsy for exams are that valproate is just not used for young women. Valproate not only causes major malformation in up to 10% of babies exposed to it, but much worse than that, really. It causes neurodevelopmental delay in at least 40% of babies exposed. And maybe it's 100%. Maybe it's 100% of babies that get some blunting of the IQ that is just not detected. So really, sodium valproate, very bad news for young women. And if ever there's an easier question to ask in an exam, it's about avoiding this for young women. Levetiracetam is so widely used now around the world that it usually is the right answer. If it's there as an option, it's usually the right one. A problem that can happen with levetiracetam, though, is that it can worsen anxiety. So you would not choose it for somebody with a history of anxiety. But it's such a great drug because it doesn't have interactions. It gets excreted unchanged through the kidney. It's relatively safe in pregnancy, so as it seems. And it's useful for every type of seizure. So it really is the go-to drug these days. Carbamazepine is something that can make myoclonic epilepsy worse, and so that's a common question. We would prefer someone, if they're male, to have valproate with juvenile myoclonic epilepsy, or levetiracetam if they're female. Females get the second best option there. And something else that comes up very commonly in exams is the driving rule. So after a single seizure, it's 6 months, of course. After more than a single seizure, it's 12 months. Incidentally, the new definition of epilepsy since 2017 is that if you have a risk of a further seizure greater than 60% in the next 10 years, then you have epilepsy even after a single seizure. So someone with a single seizure who's got a scar on the brain that's visible, who's got a wildly abnormal EEG, for example, they would be considered as having epilepsy, and hence might start on anti-epileptic medication and would require 12 months off the road. So head injury, an important thing again for exams, because it's just so important to know about the history, say, of an extradural hematoma and of subdural hematoma. So extradural is an arterial bleed. It is something which happens when you tear the middle meningeal artery, usually with a fracture of the squamous temporal lobe. And of course, you know that if somebody falls and hits their head, they may then carry on as normal for a lucid interval, maybe even a few hours, before the extradural hematoma builds up to the extent that it starts squashing the brain. And it squashes the brain and it cones slightly, a tentorial cone of the medial temporal lobe, pressing the third nerve on that same side, dilating the pupil. So that's a story that you will see frequently in exams. Subdurals, however, are venous. This is an ooze of blood. The whole thing is much lower pressure. And people who get subdurals are those who've got cerebral atrophy, and yet their skull is the same size as it always was. And so the brain might move around in the skull and potentially tear some of the bridging veins. And it's particularly important in somebody who is on anticoagulants, say for atrial fibrillation, who falls. So anybody who is anticoagulated presents with a head injury to the emergency unit will require a scan looking for evidence of subdural. But remember, subdurals can carry on growing over a matter of weeks. And so the first scan may be deceptively normal. I put down the duration of the post-traumatic amnesia because the severity of a head injury is judged by how long is the period of post-traumatic amnesia. So, for example, if it's more than 30 minutes, it's called a moderate head injury. More than 24 hours is called a severe head injury. But a lot of head injuries are less than 30 minutes of loss of memory after a head injury, and they're just minor and have very few implications for the long term. So it's not necessarily how much blood is produced and how big the cut was on the head, even whether there was a skull fracture, unless the skull fracture is depressed. It's the post-traumatic amnesia. So the next thing to consider is Glasgow Coma Scale, which I did slightly rubbish before as a form of question in an exam, but it is a common question. And so if you're doing neurological exams, you need to know about it. So Glasgow Coma Scale, developed in the 1970s, really important because it gives a reproducible way of assessing a drowsy patient consistently. And it's even used for the definition of coma. 242 or less on the Glasgow Coma Scale is the definition of coma. But one point about it is the difference in the motor response between flexion withdrawal and abnormal flexion. So when you flexion withdraw, you have your shoulder abducted. That is a normal form of flexion. Whereas if you have your shoulders adducted as you withdraw, that is abnormal flexion. I think actually anybody asking that question to anyone except a specialist neurologist would be a bit unfair, but some people do when they write questions. So just beware of that. But we're after the best motor response, the best verbal and the best eye-opening, and usually it will be broken down in that way when you give the score. We don't tend to just say the GCS of 14, etc. So Parkinson's disease is, of course, the most common of the movement disorders that you're going to see in an exam, whereas the most common overall is essential tremor. But Parkinson's disease has the classical triad of tremor with rigidity and bradykinesia, and typically it is one-sided. So hence it's distinguished quite clearly from other forms of Parkinsonism, which are more often bilateral and more often have things like early falls. So the red flags are things like falling early, not responding to L-DOPA preparations, and having other features which might suggest progressive to supranuclear palsy, falling backwards, for example, corticobasal degeneration, alien hand, and so forth. I did say I wouldn't talk about corticobasal because it's so rare, but I will talk about these non-motor symptoms in Parkinson's disease. So non-motor are things like the dementia with Lewy bodies, the visual hallucination, anosmia, something we hear a lot about with COVID, but it's well recognized that people with Parkinson's disease lose their sense of smell quite early on, sometimes long before they are diagnosed with Parkinson's disease. Having dystonia in response to L-DOPA treatment is quite characteristic of Parkinson's disease and almost diagnostic. You wouldn't expect to get dystonia for if you're given L-DOPA for other conditions. For example, DOPA responsive dystonia, don't get dystonia as a side effect. And gambling is a side effect of DOPA agonists. So that crops up in exams quite often, that a scenario of a patient who suddenly uncharacteristically gambles their fortune away, often on the internet at night, and they've been put on a DOPA agonist without appropriate warning. So I think Parkinson's disease will turn up, but mostly how to distinguish it from other forms, including essential tremor. So I put here this is a bit of a distraction really. This is a beautiful painting that is in the National Gallery in London, and it's of Samson and Delilah. And it is Samson in his post-coital weakness here, but he's having his hair cut by a barber while some soldiers are looking in, as you can see, ready to pounce on Samson, whose secret, of course, is that his hair is his strength, and the moment he loses his strength, he will be overpowered and blinded, poor chap. The story ends, however, with Samson, after a while, after a few months, regaining his strength and eventually pulling down the pillars of the temple and killing everybody inside, including himself. So you could say, what condition did Samson have that a well-muscled man lost his hair and became acutely weak, only to recover later on? Well, one report was that he may have had myasthenia gravis, because with that you do lose your hair as part of the autoimmune response, and of course it's a variable weakness, but you wouldn't expect, I don't think, such a dramatic limb weakness and such a dramatic spontaneous recovery in that. So the more likely thing that Samson had was that he might have had Guillain-Barré syndrome. And Guillain-Barré syndrome, of course, would have made him weak. It's an autoimmune condition, so you do sometimes get hair loss in association with that. And then after a period of, well, not treatment, after a period of time, he regains his strength and is able to pull down the temple. So I mentioned Guillain-Barré syndrome as a very important condition in neurology, but certainly in exams as well. It will keep cropping up with how you investigate and how you preserve the life of somebody with Guillain-Barré syndrome. So, peripheral neuropathies then, of which Guillain-Barré I put number 2, because number 1, 2, 3, and 4 is really diabetes. When it comes to peripheral neuropathy, think diabetes. We often hear of people thinking, is alcohol an important cause of peripheral neuropathy? Is thallium and all that sort of thing? They are way, way down the list. It's diabetes that causes peripheral neuropathy in exams. And this important one at the bottom I put, chronic inflammatory demyelinating polyradiculoneuropathy. Radiculo means nerve roots. So it's many nerve roots and many peripheral nerves affected in this condition. It's really the chronic form of Guillain-Barré syndrome. It's when weakness continues to progress after a month. But quite unlike Guillain-Barré syndrome, it responds to steroids. It's usually treated, though, with intravenous immunoglobulin or with plasma exchange, but we see a lot of CIDP in neurology service, but it does crop up in exams as a treatable cause of otherwise very disabling peripheral neuropathy. So I mentioned Guillain-Barré already with Samson, but just to say that when a well-muscled person arrives in the casualty and says they can't walk as well as they could this morning, it often gets labeled as functional, and people get sent away thinking that that it is all down to their divorce or their overdraft or whatever, because patients are often only too willing to believe that. But the key thing is that they have lost their reflexes early. And of course, you know, I think that the protein in the CSF is high, but the cell count is normal. The same applies actually to CIDP. The Guillain-Barré syndrome, though, life-threatening. And the one thing that we must think of in it is to check the vital capacity. People will not be breathless in the sense that they are with emphysema. They're not sitting on the edge of the bed fighting for their breath. They are quietly losing vital capacity until eventually it drifts down to the level of their tidal volume, around about 600 mils. And once it reaches 600 mils, then that patient will stop breathing and will not be making too much fuss about it. Will die quietly in the corner. So we have to anticipate this and measure the vital capacity. And as soon as their VC drops to a litre, they go onto an ITU and have a ventilator warmed up next to them. The other thing that we need to think about is DVT prophylaxis. So someone who suddenly loses their ability to walk for whatever reason, if they've got normal muscles, well-perfused muscles, will be at high risk of developing a venous thrombosis. So Guillain-Barré syndrome, don't forget to give DVT prophylaxis. It gets treated with intravenous immunoglobulin. So a couple of things to do with mononeuropathies then. So this is a man with progressive muscle thinning and tingling over his little finger. I think you probably straight away recognize that as ulnar nerve. An important muscle here is the first dorsal interosseous muscle, the one between the thumb and the index finger, which you can see here is wasted. Tingling over the little finger, not extending onto the forearm, very characteristic of ulnar neuropathy. And a history of tingling in the hand, waking from sleep, waking and shaking because they shake their hand, very characteristic of carpal tunnel syndrome. 30% of the population has it. We're going to see lots of people with this condition. It's therefore going to crop up in exams as well. And people may have some weakness of the thenar muscles, which are those supplied by the median nerve. This is another bit of light relief showing a soldier with a, well, he's got a very fine helmet on and all that sort of thing. But when you look closely, you see that he's got this bit of string attached to his foot and his upper calf. And what he's got is a dropped foot treated with that bit of cord. So this is an important differential diagnosis between common peroneal palsy and L5 nerve root palsy. So the main distinction here is made because in a common peroneal palsy, there is weakness of dorsiflexion, of course, they both have that, but there is weakness also of ankle eversion. Whereas in an L5 root lesion, there's weakness of dorsiflexion, but weakness of weakness of inversion, tibialis posterior. Of course, there's usually not too much difficulty because someone with an L5 root lesion will usually have sciatica. They'll have back pain, and it's obvious, but it's an important exam question. So something else to understand is the naming of the nerve roots and the space at which they come out, because this is a very easy exam question to ask. So the L5 and the S1 nerve roots are those that are most commonly pressed by discs. But as you can see here with the arrow, the L5 nerve root gets compressed at the L4-5 disc space. So, and then emerges as it does between the L5 and S1. And the S1 nerve root, although it emerges halfway down the sacrum, the place it gets squashed is at L5, S1. It gets squashed higher up because the pressure on the nerve happens owing to a posterolateral disc protrusion. And where it gets the nerve is long before it's emerged. So it's a slightly funny one. It's not the same level at which the nerve root emerges from the spine. It's the level at which it gets squashed by a posterolateral disc protrusion. So that will come up quite a lot in questions because it's just so easy to write those questions. So stroke is a really important condition, of course. Important to realize that it presents with negative symptoms, so with numbness and with weakness, whereas a seizure presents with positive symptoms like shaking or sometimes with sensory symptoms. That it's very rare to go unconscious immediately in a stroke. That happens usually after 24, 48 hours when there is swelling of the brain and coning and compression. But you don't usually go unconscious straight away in a stroke unless it's a basilar stroke or something involving the brainstem. But we do need to know about thrombolysis of stroke, and that we've got this window of 4.5 hours after the onset of a stroke in which thrombolysis is effective. But the earlier you can get it in, the better. So don't wait 4.5 hours unless you have to. And the various contraindications to giving thrombolysis as well. Someone who has a stroke when they wake up in the morning has an undefined starting point for the stroke and therefore cannot be safely thrombolyzed. We need to know about the Chad's-Vas score as well. This is the risk of stroke in someone with atrial fibrillation. This is actually quite an easy question to write again, just remembering that women have a higher risk of stroke after atrial fibrillation, and so they are awarded 1 point just through being female, even before they reach the age of 65 or 75. So Chad's-Vasc crops up quite a bit in exams. And another sort of stroke that we see in exams simply because you can work out the anatomy from it is a spinal stroke. So anyone with an abrupt onset of paraparesis, particularly at the T10 level, may well have had an infarct of the anterior part of the spinal cord. Of course, the anterior spinal artery one artery supplies all of the anterior spinal cord, but it doesn't supply the posterior cord, and hence you get a differentiation in the sensory loss. You get a dissociated sensory level where you get sparing of dorsal column function. So this person with a sensory level at T10 will have normal position sense in their feet. And brain tumour will crop up, but to know that the commonest brain tumour, sadly, is the very worst one. Glioblastoma multiforme, grade 4, is the most common form of malignant brain tumour. And but epilepsy happens in those with a lower grade of tumour. So in a way, having epilepsy as a presenting feature of a tumour is a marker of a better prognosis. Important to know about these new markers, the genetic markers which indicate response to treatment. So things like the DH12 gene gives a better prognosis for the management of this with cytotoxic drugs. It's sometimes true that we would see in questions of bitemporal hemianopia and other visual fields and so forth. Something about this is that this obviously comes from chiasmal compression, and chiasmal compression from a pituitary tumour is from below. So the nature of the bitemporal hemianopia is it affects the upper fields first. So the typical presentation of a pituitary tumour affecting the visual fields is to get a bitemporal upper quadrantanopia as the first finding. And it may just be that you lose colour vision in the bitemporal upper fields, but that's where it all starts. So a good endocrinologist carries around a red pin with them. So someone presenting with double vision with a cranial nerve palsy, this is somebody actually who's presented with ptosis and probably doesn't actually have double vision until you open up their eye and you find that their eye is down and out, and with the fixed dilated pupil of a third nerve palsy. 3 components to a third nerve palsy: complete ptosis, eye down and out, and pupil fixed and dilated. And this can be caused by anything along the track of the third nerve, particularly posterior communicating artery aneurysm. Something about the trigeminal nerve, because again, this lends itself very nicely to questions. An important point about the trigeminal dermatome, the ophthalmic division anyway, is that it goes right back to the middle of the vertex. So not just the forehead as you think it might, or as you think it might do. So someone with facial weakness, the most common symptom, most common cause of this, of course, is Bell's palsy. And someone with Bell's palsy would have other features as well, particularly hyperacusis. So as well as the complete loss of movement on the one side of the face, including the forehead, they will have loss of chorda tympani function and hence may lose may lose the dampening of hearing, and so they get hyperacusis. Much less common to lose any taste. So this is a painting by Goya, and I mention that simply because Goya himself had a neurological problem. Goya became deaf at the age of 47, profoundly deaf actually, and at a time when it wasn't really, there wasn't any proper rehab for that sort of thing, and he became very lonely, and his painting changed to being very dark like this, as you can see. The same view on this painting, which is painted at a time when he became very depressed later on in life. But he lived to the age of 80, so whatever caused it, it wasn't syphilis or anything like that, but it might well have been a form of bacterial meningitis, possibly, of which he made a surprising and miraculous recovery. We're going to see meningitis in exams mostly in the form of CSF results and a bit of history. So you need to know, of course, that bacterial infections, there's a high white cell count, and these are predominantly polymorphs with a low glucose. That a viral infection has a high white count, but they're mainly lymphocytes, and the glucose is normal. And TB is a tricky one, where you get a mixture of polymorphs and lymphocytes. The glucose is low. The patient is often immunosuppressed and often lived abroad and that type of thing. When you see meningococcal meningitis, the treatment is to get the antibiotic in early. So it's often given by the GP at home, the first dose, and that is the right thing to do. So we're going to see that type of thing cropping up in exams. Motor neuron disease, not treatable very well, unfortunately, but it sometimes does crop up. It's motor only, so any sensory symptoms or signs would mean that's very unlikely. It's the combination of upper and lower motor neuron signs in the same muscle. So, for example, a patient with brisk reflexes in a fasciculating muscle would be having that both upper and lower motor neuron signs. And I put down the split hand because here, instead of the usual anatomical split between the ulnar and the median nerve that we've seen, you might get someone with wasting of the thenar and wasting of the first dorsal interosseous right next to each other in the same sort of motor unit, but sparing of the medial hand. And that is a sinister type of finding and suggests it might well be motor neuron disease. So multiple sclerosis, again, a very common exam question, important because increasingly it's treatable. It's a central nervous system disorder, so it doesn't affect the peripheral nerves, but it's the white matter of the brain and the spinal cord that are affected. And it's treated with disease-modifying treatments, DMTs. We know also about the dissemination in time and space, and that can be refined these days with MR scanning, demonstrating the dissemination in space and time. About 1 in 600 people is the prevalence of multiple sclerosis. So it's common, and it's particularly so in younger people. I'm just going to quickly finish with some words about test-wise candidates. So this is a question which doesn't have a proper stem, just saying which is the most likely, sorry, what's the most likely answer? What's the risk that this child has this disorder? The answer is that if you're not careful, then the best answer is C, because when somebody writes a question and the answer really is 1 in 200, they think, well, how can I conceal that answer? I know I'll put a couple below, a couple above, and the candidates will never find it. But in fact, they're drawn to it by a convergence straight on letter C. So I would say to you, if you have a list of numbers like that, think answer C until proven otherwise, because unless somebody's aware of this, they might not realize when they're writing the question that they're feeding you. Another test-wise answer is when there are things like clopidogrel with aspirin or clopidogrel alone. Well, you know, why would you have an answer aspirin if it weren't the correct one? So I would say go for the answer with 2 options if all of the others have 1, because you know that there's otherwise no point to having it there unless it's correct. And similarly, if you have a list of 2 drugs or 2 components in each of the 5 options, well, one way to see which is the most likely is which ones appear most frequently. And in this question, there are 3 9s and 3 10s. So my money would be on A, because what the question writer has done here, rather foolishly maybe, is say, well, the answer is 9 and 10. I'll have 9 and something else, 9 and something else, I'll have 10 and something else, I'll have 10 and something else. and then it's all neatly concealed, but it's not. So in conclusion then, I think neurology really lends itself well to questions. It's a huge spectrum of conditions within neurology, everything from the cortex down to muscle via the spinal cord, etc. There's a lot of clinical medicine in neurology that can be tested. So I would like to hear any feedback on this, or if you have any questions, then please put them into the designated Slack channel, and I'll try to answer them for you. So thank you very much for listening.
Thank you, Professor Smith. That was great and a really interesting insight into the speciality of neurology. Please do post if you have any questions in the dedicated Slack channel if you want to ask Professor Smith anything. Our next speciality webinar is coming in the new year and will be an insight into performance under pressure by Dr. Mark Stacey, a consultant anaesthetist based in Cardiff. Please look out for our future speciality webinars and other materials produced by Medics Academy. You can find out plenty more information about our services at www.medics.academy. Thank you very much for tuning in this evening. And I'd also like to take this opportunity to wish you a very pleasant Christmas and New Year.